The next session today, before we break for lunch, will show us how care coordination is not a clinical luxury. It is a systems necessity. And in a health emergency, the absence of coordination can be the difference between containment and catastrophe. We will begin this important session with a spotlight presentation by Dr. Shalini Singh, CEO, Arohan. She founded her consultancy, Arohan Partners for Advancing Health Systems, drawing on 20 years of experience guiding government health programs. She was a key member of the team that drove the rollout of Ayushman Bharat's health and wellness centers, the primary care backbone of India's universal health coverage program. I invite you, Dr. Shalini, to please share your expertise with us today. Thank you.
Thanks, everyone. Thanks, Tuti, for the introduction. Am I visible to everybody? I have a feeling that the podium is kind of blocking me. So, trouble with short people. But before I dive deep into the scientific information about care coordination, I want to start my presentation with a couple of caveats. Uh, I know that the topic which has been assigned to me is care coordination from the perspective of resilience. But we heard an excellent panel early in the first half of the day, which called resilience as not something which helps us bouncing back, but also helps us in bouncing forward. We also heard that primary healthcare is unnegotiable for resilience. And I want to present care coordination uh, understanding today from the lens of primary healthcare and why is it important. Uh, So this is a double helix, very familiar to all of us. Can one of you just identify what this image is all about? What does it remind you of? It's the DNA, yes. I'm a design researcher by training. So in human-centered design, we strongly encourage people to develop mind maps. So when I started working on care coordination, I first thought of, okay, let me prepare my own mind map about what care coordination is actually all about. And if you see the image, the complexity of the loops, which are both on the right side and the left side, look very convoluted and complex. They basically, in my mind, I felt that they represent the patient care journey, both upward and downward. You see the bonds which basically exist between the two loops, and these are the interconnections and the care linkages which are required for care coordination. Like DNA, which forms our code for a well functioning body, a human body, care coordination is that inner code or that underlying code which is important for a very robust and functioning, well functioning primary healthcare. It's the essential core element of primary healthcare, but like DNA, not always very obvious. So, how are the two things interrelated? When you see the WHO framework for person centered care, continuum of care and care coordination are always written together and they are mutually complementary to each other. If care coordination is defined as an approach of bringing together providers and health professionals to meet the needs of service users, to ensure that they receive integrated person centered care across various settings, continuity of care actually enables how their journey is, how they experience healthcare events across their journey when they seek care. Care coordination basically leads to conditions and situations which support continuum of care. What is evidence saying? Have care coordination models been tested before? Yes, across the globe. They may not be holistic, they may not be very comprehensive, but each country in its own way has tried care coordination models. Now, why have they been tested? We all accept some of these challenges which have been listed here are all applicable even in India's context. There is fragmentation of care. We experience it ourselves when we go to a healthcare facility. We do need to do so much of running around. The diagnostic lab is not talking to the physician. The pharmacy is not talking to the diagnostic lab, and most of them are operating in isolation. In our own context, we have been traditionally a country, our health system has got used to of working in silos through our vertical programs. We face weak continuity and referral system challenges. There's poor linkages between levels of care. When we go to the field, we do field interaction, we still come out with issues and barriers where a home delivery has happened because of weak referral systems. A mother has been referred to multiple levels of health facility because of referral challenges. Uh, Information and communication exchange is still a problem, both from tertiary care or secondary care facilities down to the ASHA level, and also from the ASHA to the upward level, and from health and wellness centers to the district hospitals. It also impacts quality because there is, you will see that there is a heterogeneous adherence to standard treatment guidelines. What's written in district hospital is usually not available in the PHC system. Now, how do these challenges are experienced by the people, by the health providers, and also by the health system? So, I'm not going, given the paucity of time, I'm not going into the specific statistics for each component here, but this slide mainly talks about the maternal and newborn related health challenges as experienced by the individuals because of care coordination gap. One classic thing which is coming to me here to demonstrate is the last one, where despite all the achievements, despite all the efforts that National Health Mission has put in, till now, only 15% sick newborns are referred with a referral note. How are patients suffering for chronic diseases? This is the most obvious thing. We know the statistics very well. We know that 22% non communicable diseases related deaths are preventable. And there is evidence which is saying that if care is well coordinated, 22% males and 90% females who face premature mortalities could have been prevented. Their risk factors could have been managed. We also know that only till now in India, only 28% people with high BP actually know that they have BP. And even those who know, only 52% are able to continue their treatment. Follow up care is an individual's responsibility. It relies on patient's agency to go and take follow up care, but the proactive outreach which a primary health care provider should ideally do to bring these patients back and take care of them through follow up visits does not exist. Now, why do providers struggle to coordinate care? Many a time you would see that providers delay care, they delay referral, there is poor case management, and this has been associated with 92% of maternal deaths, making clinical decision making and timely escalation of care a critical need. Providers also lack clarity, like how do you work together and how do you work across facilities? What is my role? What is their role? Most obviously seen in chronic diseases like cancer. What is a palliative care person expected to do? How this palliative care person can talk with the specialist or the oncologist. We also see challenges in referring patients to the appropriate facility because of unstructured referral mechanisms. There's some evidence which is also saying that it's only 16 out of 15 facilities that they tested for a study in South India. They actually were able to track diabetes through an EHR. There is interpersonal communication issues between primary care providers and also teams which are working in higher level facilities. As a result, one doctor doesn't know what to write, what the other doctor has prescribed. So there is a very high chance of irrational care. I'm skipping this slide for time paucity, but yes, what are the health systems gaps now which are undermining care coordination? Number one, it's also a tendency. We straight away jump to higher level facilities irrespective of the seriousness of the illness. Part of the reason is because Most of our primary care facilities do not provide the comprehensive care that usually patients and individuals require. 40% of our urban residents visit specialized clinics and hospitals straight away, leaving these tertiary hospitals to face overcrowding and with long waiting times. We also struggle with the program management and monitoring systems, which are not fully equipped to the growing burden of NCDs. We have moved a way forward in the last 7 8 years with the introduction of Ayushman Bharat and the NCD application, but still the kind of usage of these digital platforms to enable care coordination, to use the data from these applications to plan health promotion and lifestyle improvement strategies for population above 30 is yet to be seen. Our two policies for Ayushman Bharat still remain fragmented. We have no interconnections and coordination linkages which have been formed if the patients are discharged after availing care under PMJ. So, what is the evidence from Southeast Asia saying about care coordination interventions? What kind of interventions actually lead to care coordination? I'll draw your attention to the community and home-based care, which was to me was the most familiar understanding of care coordination. We have community health workers, we have ASHAs. Why were they introduced? Absolutely to bring care coordination, bring community closer to the system, bring that linkage between community and the health system. There is a concept of patient support groups, partially rolled out in South India, but not so evident in North Indian states. Nurse led care, family physicians. You have heard about care coordinators. There are isolated interventions of care coordination where patient care coordination coordinators or patient navigators have been used. The concept of multidisciplinary team you will see in isolation, like somewhere in some blocks, some villages, uh, the ASHAs or the CHOs and the ANMs and PHCs. Medical officer are trying to come together as multidisciplinary team, but there is a lot of efforts which are required, particularly in areas of elderly care. Digital technology, we have enough examples within India which show and use EHR for care coordination. Telehealth, eSanjeevani is a big example. Uh, Many pilots on use of digitally enabled care coordination system for uh, for clinical decision making. There are also some isolated examples which show within the public health system that how a digitally enabled care coordination system can lead to improvements and improve health outcomes. The two examples which come to my mind here, and I've listed them, is the STEMI initiative. Government of India recognized it as best practices way back, I think, in around 2018. This is basically a care coordination system specifically developed to address ST elevation in myocardial infarction. The STEMI program was first piloted in Tamil Nadu. This strengthens care coordination and case management, which is again a very strong linkage to enable continuum of care. It links primary care centers, smaller hospitals, with tertiary centers and also the ambulance, bringing a hub and spoke arrangement. The ambulances transmit digitally real time ECG through a digitally enabled STEMI portal to the specialist who's there sitting in the tertiary hospital. Just by this simple initiative, the mortalities were brought down by 4%, and the chances of patients to avail the kind of treatment which is required, a very prompt kind of a treatment, there is a golden hour in which you need to do this. More effective pharmacoinvasive therapy was given for patients rather than standalone thrombolysis, and it increased from 13 to 20%. The other example, which I myself observed in the field in around 2019, was coordinated care model piloted in Karnataka to improve the capacities of primary care providers. This is a model which was tested by NIMHANS, and it is kind of a telemedicine plus a telementoring kind of an approach. We know that under district mental health program, we will never have the number of psychiatrists which we require to address the mental illness burden of our country. And so the availability of psychologists and counselors are also missing. So what did NIMHANS do? NIMHANS trained primary care providers, through an in-person training for 1 or 2 days and then sent them back. And then these doctors were tele-mentored and guided by the psychiatrist from NIMHANS or the psychiatrist, that one single psychiatrist who exists in the district, possibly under the DMHP, to guide them on providing treatment for mental illness. And if you will see, look at the number of patients which have been covered, more than 20,000 patients. I'm quoting this paper, which is also 3 years old. For PHC doctors, there was a skill transfer rather than knowledge alone. Uh, there were several other benefits, but what is really seen here is 17 to 46% range of primary care settings uh, indicates like the prevalence was 32.24%, and all these patients were treatable using this telementoring approach. For the community, it meant that there is less burden of psychiatric disorders, early treatment, and it made uh, it made patients' life more functional. So, in nutshell, care coordination is a triple win. It has benefits for patients, it has benefits for providers, and it has benefits for health systems. Of course, to us as patient, it means early diagnosis, treatment initiation, reduction in OP, more efficient care. We don't have to go and undertake multiple referrals. We have continuous monitoring, treatment adherence. For providers, it means that they have a very well organized task coordination mapped out. They know their roles and responsibilities. They have access to patients' complete health records. There is continuous and tailored communication. More importantly, teamwork, which is now needed more than ever before, given that we are becoming a country which is becoming older, and we are facing diseases which have multi-morbidity needs, which cannot be addressed by a single provider. For the health systems, it reduces dependence and overcrowding. We can better manage our chronic illnesses and long term illnesses. And transitional care, we know how to hand over patients to the community, and then what do community providers do to bring the patients back to the upward care for tertiary and secondary care. We minimize duplication of efforts, provide rational care, and then there are, of course, better linkages between primary and secondary care, which is covered under insurance program. So that's the end of my presentation. Thank you.
Thank you so much, Dr. Shalini, for that insightful presentation. I would now like to invite the esteemed panel to the stage. Moderating this session is the CEO of Access Health International, Dr. N. Krishna Reddy. Sir, Dr. Reddy, please. Rejoining our panel and bringing the operational perspective of a state government that has demonstrated what resilient care coordination can look like is Additional Chief Secretary for Health and Family Welfare, Government of Kerala, Dr. Rajan N. Khobragade. Request you to please join us on the stage again. Next, we have Dr. Abha Mediratta, a faculty and improvement advisor at the Institute for Healthcare Improvement, IHI, and a non-resident fellow at the Center for Global Development. She specializes in clinical guidelines, quality standards, and the health benefits package design. If you want to know how to engineer quality into a health system at scale, she's one of the people you call. Next, we welcome Dr. Santosh Mathew, a political economist and former public administrator. He now leads the public policy and finance portfolio for the Gates Foundation in India, focusing on strengthening state capacity, public finance management, and health systems design. He understands both the policy machinery and its on the ground realities. Welcome, sir. Dr. Sarang Dev, who was supposed to join us in person, unfortunately had significant flight delays early in the morning, so he's joining us virtually. And Dr. Sarang, we are mindful of your next commitment. But just to quickly introduce you, Dr. Sarang Dev is the Deputy Dean for Faculty and Research at the Indian School of Business, Hyderabad, and Executive Director of the Max Institute of Healthcare Management. His research on operations management in healthcare delivery and supply chains has shaped how we think about systems efficiency. Over to you, Dr. Reddy, to moderate what promises to be a truly rich discussion. Thank you.
Yeah, thanks. I will stand from here and try to moderate the session. Uh, Deep apologies for the delay to the panelist for the time. Of course, it's not in my control. It was in the preceding speaker's control. But I think that the session objective has been, while the access to care is improving, affordability is improving, however, the outcomes continues to be poor. I think that's the case that I think everybody is trying to understand what is affecting this outcomes failure despite being available access and improving affordability. I think that is where a lot of teams, a lot of theoreticians are attempting to actually address these outcomes issue as to what are the process gaps that may be there which need to be addressed. Given the fact that the health systems have fragmented in the last few years, there are multiple specialties, subspecialties. There is modern medicine and traditional medicine. There is public sector and the private sector. There is informal and formal. And the patients navigate through this complex, the health system. I think that's where we are trying to see who is actually helping these patients navigate this complex health system, who is coordinating these patients. In Kerala, I think, as Rajan has pointed out in the beginning, Kerala takes a leap to actually demonstrate what can be done in terms of the care coordination in a public healthcare delivery system. Some of the people, like in the UP, trying to attempt as a payer how they can actually improve the coordination among the beneficiaries of the public health insurance. Among the private healthcare, in terms of looking at public health, because the patients are navigating between both public health and the private health, will the public health department actually oversight and enable coordination of the patients across both the sectors, between the public sector as well as the private sector? So one is providers coordinating, payers coordinating, the public health department coordinating. I think these are the three dimensions that we may be looking at. I was to actually add a different sequence of calling upon the panelists, but since Sarang has a upcoming session, so he has the privilege to be asked first. Welcome, Sarang. I think my question to you as a researcher as well as a business teacher and is, since theoretically a lot of things which are being tested in terms of that the care coordination translates into improved outcomes. This is the thesis. Similarly, interoperable standards-based electronic health record system will enable integration of fragmented healthcare and enable a smooth, seamless flow of care coordination. From a researcher perspective, what are the methods of testing this hypothesis that this is actually yielding results in terms of the improved outcomes and reduced costs? Maybe, you can outline, I might have changed the questions, but the essence is same as to how do you actually validate this hypothesis that the care coordination will improve the outcomes?
Yeah. Can you hear me okay?
Yes, yeah.
Okay. Dr. Krishna, thank you for the invitation and for organizing this wonderful event that I couldn't attend, unfortunately. And thanks for the question as well. The presentation that just preceded this discussion was quite comprehensive, right? It laid out a lot of challenges. It also laid out outcomes that one should measure to check whether care coordination works or not. As a researcher, I can share some of the experiences, right? As there are challenges in the health systems, there are also challenges in evaluation. And one of the biggest challenges in evaluating care coordination models is that they span multiple levels of health system by definition, right? So I'll give you an example. A lot of discussion has been on public health system, and you just mentioned private. So let me take a private example. Okay. Imagine you want to do an early diagnosis of diabetic retinopathy. Right now, what's the place to do that? Definitely not an eye clinic or eye hospital. Most likely endocrinology practice or diabetes practice. In the private sector, there's a separate clinic that does diabetes treatment, diagnosis, etc. There's a separate hospital or hospital chain that does eye care. Now, one is how are you going to do an early diagnosis of diabetic retinopathy? You can bring in some technology. Okay, so there are cameras today that have AI enablement. You can screen people. When you do that, you get some people at risk of diabetic retinopathy or some score, right? Now, take this point about, okay, these patients now need to be referred to an eye hospital, right? And in most cases, we would say referral is linkage to care or is some aspect of care coordination. In our experience, it turns out that it leads to zero patients being actually presented at the eye clinic. If you just say referred, just give them a slip, referral slip. And when you start getting into the nitty gritty of it, it turns out that eventually what you need to do is that the two appointment systems in these places need to actually talk to each other. Which means once I identify a patient who needs to go to the eye clinic, that has to ping the appointment system in the eye clinic. And then a slot has to come back. And then that slot has to be printed on a letter because patients may or may not have access to digital technology, at least a piece of paper. But before that patient leaves the diabetes clinic, they should get an appointment slot. If that is possible, then there is some hope that the patient shows up in the eye clinic, right? Again, I'm talking about the challenges of actually achieving care coordination in private sector, but then you can also start to imagine challenges of measuring whether care coordination is achieved or not. This is inter-facility coordination, and I can talk about one example from intra-facility again, right? Which is, suppose you can take the eye hospital example, but you can use any tertiary medical college example here. Patient presents for complaint A, chief complaint A is seen by a consultant, and then realizes that there is a complaint B also that the patient needs to be cross-consulted for. Even in most advanced appointment systems today, there is no provision to insert this cross consultation. So, most likely, this patient is just told go to that block C where you may be seen by some doctor, or it's on the fourth floor of this building or whatever. And then physical navigation of the patient, of course, is one issue. But when the patient shows up there, that patient is actually a disturbance to the flow in that other clinic, right? Because it's not a legitimate arrival in that clinic, and then the patient may say this is too much of a headache and may go away, right? So even within the same facility, there'll be challenges in achieving this level of care coordination, and we often tend to underestimate how impatient patients are, how quickly they lose interest. Because the value of this care coordination is not apparent to patients upfront, right? It is something that the health system or health providers are seeing, but they cannot communicate this. So I'll pause here, and I'm happy to answer follow-up questions. But in terms of measurement, metrics were already mentioned. I think costs, delays, which all are predictors of eventual outcomes. Outcomes are very difficult to measure. Take diabetes, hypertension, outcomes may be downstream, but these proxies of those outcomes that we can measure today would be a starting point. I'll stop here. Thank you, Krishna.
Yeah, thanks, Sarang. I think you brought out some fundamental issues of intra-facility, inter-facility coordination challenges, and also the metrics, whether it is the process level metrics or the outcome level metrics or the infrastructure level metrics. I think these are evolving. I think the practical examples that are happening in some of the private systems or the public healthcare systems may bring out some much more insights into these things. One of the simple mechanism of coordination, Santosh remembers me in CMC Vellore, I was talking, what we do in the hospital, only two things. We write in the medical records, we hand over the patient, right? So the same thing can be done between the departments, between the facilities, between tertiary care to primary care. So you basically need to pass on the information and pass on the patient through a handover mechanism. A nurse to, because this is a standard in any hospital, we hand over to the next duty doctor. The nurse handovers to the next duty nurse. Recently I started my IP nurse hands over to my OP nurse. My OP nurse hands over to the clinic nurse. Clinic nurse hands over to the home caretaker. So just introduce this handover system. I think we may be able to overcome some of the challenge which, while digital enables and drives efficiency, this simple human process also can achieve the same objective. Just I wanted to, because I'm a practitioner, so I wanted to convene from my own experience. Maybe I will come to, Sarang, I will come back again, I think, during the discussion in case you are not held up with the meeting. I would like to come to Sri Rajanji. I think you are also have to have an appointment. I think in the morning, what Rajan has outlined in terms of how they're translating some of the conceptual understanding around One Health into action over the last 5, 6, 7 years. The same thing that you have initiated in Kerala in terms of how initiative around the care coordination to drive efficiency in the system, to drive care continuity in the system, and to reduce crowding in the public hospitals. What has been, I think that's a rich sharing of what exactly happening and how it is shared, and what are the challenges iteratively from a policy perspective that you're trying to address.
I'll give some context. This what has made us think to see that whether in normal times we can use some of our experiences of the past, and that is what in the morning also I have highlighted, that the health system should be always a learning system. It's a dynamic thing. So whatever we are experiencing, maybe successes or failures, it should give us an input. So if we again, take COVID pandemic, and as we are saying that we need to take a look at how we work, not only related to the pandemic, but also the non-pandemic. So we were having a system to identify what is the total number of bed-bound patient in the state. So we are having a very brilliant palliative care grid. So we were knowing even during COVID time that how many patients are bedbound and what are their requirements. And today also, if you browse Kerala Care portal, you will come a real-time basis how many patients are registered and how many patients are getting all the services what they require. We have also called out the information regarding how many transgenders are there. And they are all during lockdown. In fact, nobody will be going and meeting them and all. So what are their requirement, including day-to-day survival ration? So those food kits were provided through our, field workers to them. And we come to the chemotherapy, how many cancer patients were there that were known to us, and we have provided daycare chemotherapy to them. Today, more than 1.5 lakh patients are getting daycare chemotherapy at the field level hospitals in our taluka hospital or the district hospital, wherever we have built that kind of a capacities. So then we thought through, after this whole pandemic phase is over, then what next? Because we need not only keep on saying that we have done these many things and during pandemic and all. So from that thought process, we looked at during normal time how we can take a look at it. And here, I must say that, Access Health is also our partner. Santosh Matthew sir also has given us a guidance. And then we, worked out this concept that, what we have done during COVID time related to the navigation of the patients during the treatment requirement, because we were having 5 layer of system. At home, people were there. Then we were having COVID first line treatment center, second line, and tertiary centers, and the COVID hospital for the very serious kind of care which was required. And we have created the beds outside the hospital setting, that is the hospital, government hospital, private hospital, plus field hospitals in schools, colleges, and auditorium. And some of the places also we have kept the cylinders and all. So, non comorbidity patient, but requiring oxygen and all that we provided even outside the hospital setting in the field hospital. So there were perfect, protocols, and we were having the control rooms in all the district. So it has given us an enormous experience that how we do the load balancing. So if we get the information that from this inpatient is now getting serious, so we were having on the maps in Ernakulam or in all the districts that these are the places. So it was mapped in hospital these many rooms with oxygenated beds, which is occupied, which is not occupied. And then they used to see that okay, this is the flow which is coming in this nearest hospital. There are these beds, and we have already done the unit costing. Be it a private hospital, we will send the patient there because that patient can reach there fast. And therefore, even during the very difficult time which other states have faced, there was never a difficult time in the state of Kerala where patient remained outside the hospital and they could not reach to the hospitalization of the beds or the oxygen. So now we learned from there, and then we said that during normal time, the patient is having some ailment, why straight away they should rush to the hospital where they would like to go. So we have done the two-prong approach. One is the supply side, one is the demand side, in fact. And that is the strength of Kerala, in fact, because we have to do community engagement and educate them and make them aware regarding that the ailment is a minor ailment, and therefore the very qualitative, efficient treatment can be given at our family health center or our CHC or our Taluka hospital. And you need not rush to the straight away to our general hospital or the district hospital or medical colleges. So we have done a whole ground setting after studying everything. And I will request my colleague Papu to show the pathway that patient journey is like this. The person is having some kind of a issue, then they would like to get the health services from the health service outlets. It can be at a different level. In fact, it can be in their villages or the place where they are staying next to that, or it goes to the higher. So we have studied this patient pathway, the what patient, and then we are having these links in between that we have studied, that where this information should lead, then from there where it should get passed on, and then from there how what all things we will provide to that patient. So whether we can have a pre-check facility, what we used to do during the this emergency, the whether we will have that kind of a setup, and then this information will flow everywhere. And we are having a very strong backbone of e-health, what we extensively used during COVID also, with e-Sanjeevani platforms and other things, and the Disha center. So what we have done, that what all human resource we are having in the hospital setting, what all the digital infrastructure we are having, and what can be done a matching or some kind of a capacity building by which all this pathway becomes very, very strong. So with that kind of idea, that we have gone ahead and we have selected Trivandrum in the district because we are all there. And I must say that my team, Dr. Vinay, Arun from Access and Papu from Access, also guidance from Dr. Santosh Matthew sir, and also DMOs and all these hospitals, we have selected first one pilot, that we have taken two health blocks having 11 institutions, and we have selected FHCs, Family Health Center. We have selected their first referral, which goes to the Taluka Hospital or CHC. And then we have taken the secondary level, that is our hospital in Naya Tinkra and DH, and then tertiary level medical college and dental college. So what we have done is we engage with that panchayat in that particular conical kind of a design. And Papu, can you show that the map of Trivandrum where we have selected this pilot area and this? Now, what usually happens that the patient, I am at home, from there I need to go to the hospital. So we have done that kind of a mapping that from this geography, in fact, the referral will go to a particular, the next referral point. So they were knowing that the catchment area and also the hospital which may be receiving, they will know. And then we have done this interconnected with our e-health system, which is already implemented, that the patient were encouraged to come to the first point of contact. And from there, they referred properly and given the appointment also. As per their convenience, time slot also is there is a system which gives them a time slot. That information goes to the higher level. and then this individual, referred, went there. Now that is what we have put to practice. Now initially there was a problem, but now we will go to the slide which will give us a clarity that what actually was happening in our state. Long back, in fact, in 2017 onwards, when Aadhaar was there, at the same time, in fact, we have also taken initiative. We should have a unique health ID. Everybody laughed at us. This is, it is not possible. And also, but we got the support from MIT and the rest of the support from the government of Kerala. We went ahead. So we are having this unique health identity. So there we started capturing the EHR. So over a period of time, I think it will get robust, but it is going through its own, qualitative aspect, because we have also given temporary unique health ID. But now let us take a look at the outcome of all this, our pilot, what we have done. Papu, show that slide. Previously, so I was talking about, the whole conversion which has happened. Go to the previous slide. That yeah, unique health identity. Now, previously, prior to the pilot, these were the percentage of using, their unique health ID. After the pilot, this whole thing has increased because everybody is coming with their unique health ID. Now, the advantage of this patient, in fact, they get their all the historical record, what actually is happening to their health. That is also available at the click of button on their mobile. They can download and they can carry that whole history along with them. Go to the next slide. Now here we will be able to see that all these centers where we have done this pilot, the whole conversion related to the how e-health has been accessed by the patient, and what is the increase rate in every institution, that we can very well see, which has gone very high. And also the prescription through the digital system, which was lower before the pilot, that has increased. Now it is a gradual process because we have to make people totally acquainted with this, and also from the response side, from the supply side, we need to bring in efficiency. So what we have done is, based on this pilot, then we have scaled it up throughout the Trivandrum district. So now today, in Trivandrum district, all the around 171 institutions, they are on this track where the patients from the grassroots level are appropriately getting, referred to wherever required places. And we are building that kind of involvement of community by taking testimonials, going back to the panchayat wards, telling people that how comfortable it is, rather than we saying. In fact, their peer-led approach is helping us. So over a period of time, in fact, we are very confident that this will get further strengthened. Now, what we have done is, at the policy level, we have done that total pilot in the Trivandrum district. Now, in all other remaining 13 districts, we have rolled out, and we are confident that in a year's time, we will be able to make it robust. And I'm not very keen on numbers, but even if 10% people, even if they follow that, look, this is what the input I have got with the telecounseling, and I can get my ailment cured by going to FHC, it's a huge step forward. And from there, in fact, we will build the whole system, which we feel that is totally doable by utilizing the present resources what we are having. One more thing what we are working out, and hopefully it will happen, that is, at a tertiary level, we are having a little bit of issue. That is speech to text. That programming should be our indigenous program. And we are having a little bit mind block regarding this, using, all this, the engines which are available, because it's all patient related information. So we don't want to hit a roadblock, but we would like to, get, and I think Government of India, NIC, has already developed, and we will be looking forward to that, so that at a tertiary level, then I think it becomes more easy, and I think this EHR will be a continuous thing, and our permanent unique health ID, over a period of time, I think each one of us, along with Aadhaar ID, I think all the Keralite will have unique permanent health ID. That is the way we are going forward. And right at the birth, I also we are thinking that along with this, birth registration, whether we can also give the permanent health ID to that baby who is born or she is born. And that is the way we will be looking forward to strengthen our system further.
Yeah, thanks, Rajan. I think this is a beautiful uh, illustration of the iterative approach to initiative. It's not a fixed design approach. I think that's one lesson everybody has to learn. We are living in a very complex system. Don't go by mechanistic frameworks and mechanistic design systems, but more of iterative learning systems. I think the second point, which Rajan brought out very clearly, is the community awareness and community engagement and community participation. I think these three are the most essential things. And the third element, I think, that came out very clearly is that you don't ask for more resources. You innovate with existing resources, what you can do with the resources. If just one nurse is given extra competencies of care coordination, or extra competence of monitoring what is the outcome of this coordination in terms of patients referred converting into actual referrals. I mean, these are the simple competencies only we have to increase, not the number of people, new people. The third point I think he brought out very clearly is it was a foresight that the e-health system was implemented long back. But now the time has come where the technology also is getting disrupted, and there is a scope for actually leveraging the existing e-health and because that's essential for any coordination and integration. E-health is going to be essential. And the fourth thing, I mean, I wanted to ask one question with reference to, as I mentioned, I mean, while you are doing entirely in the public healthcare system, what is the policy perspective of making the private sector adopt the interoperable health record system? Because that is going to be the key thing for achieving public health level coordination. So that is, I think, one thing, what levers that you would like to use, whether it is a financial lever or whether it's a clinical establishment lever or a market force lever, whatever force lever, because those are the insights I think the country is going through the challenge of how to make public health, private health sector adopt the interoperable electronic health record system. I mean, just question.
So there are two, three things, possibilities for us to tap. One is, as you yourself said, the Clinical Establishment Act, and second. But what the way we work in Kerala Health is we build partnership. So and they are our partners in Ayushman Bharat. We call it Karuna Arogya Suraksha Paddhati in Kerala. Which is having more than over and above government of India packages. We are having more than 100 packages. So we are having 1600 plus packages, and I think 90% of expenditure is done by the state government. What we get in Ayushman Bharat from the government of India is less than 10%, and we are fighting with NHA to work it out. All the states are fighting because it is not really 60-40. But that apart, what I wanted to tell is through CASP also we are having more than 350 private hospitals, joined in our system, and they are providing the care. So they are already there from the private sector. So what ideally we would be doing is all the notifiable diseases, in fact, they are expected to give us all the information. So, like in many other program, maternal mortality or infant mortality, we are having excellent partnership with, Foxy Kerala chapter and also Indian Pediatric Association and all. So all the hospitals there, they become our partner. So regarding this also, my expectation is at the government of India level, there should be a standardization related to the what kind of applications which are put to practice in the hospital setting. And there should be essential thing which should be there should be interoperability and connectivity should be inbuilt into the applications. They can have their own applications, but there should be this one particular thing embedded. So what will happen? The standardization will happen across the country. But perhaps we may not wait for that to happen, and we will try to get that initiative done at the state level, engaging with the private sector who are already with us under CAS program, and we will tell them that, look, you are also handling the patient load by choice, and then we both of us are partner to deal with this 1600 packages. So let us have a system which will get interconnected, and the whole thing is the patient is benefited, because we are not asking that you dump all the data what you are handling to us. What we are saying is that patient is, if he is having a EHR in the XYZ private hospital, that EHR is compatible, because if that patient access health services from the government outlet, then we should be also able to get everything. We need not get into the duplication of the investigations or also further other things, and we reduce the burden on the system. So that is a possibility. It requires good policy level thinking at a top level. But I find there is a block because instead of building certain things step by step, we are all imagining, a very big mega structure, and we are saying that, well, this data policies and all, and we are all having a dialogue with ministry and everybody, and it is taking time. So I think we should take initiative at the state level, because many of the private players are also there in the Ayushman Bharat. So every respective states, wherever there is some kind of a competencies, capacities, they will be taking it forward, and then it will get scale up at the national level.
Yeah, thanks, Rajan. I think very illustrating and educating narrative of what exactly a practitioner's wisdom is coming through. Thanks again, and we'll come back in case you happen to stay back. Santosh, I think you are the sutradhari of care coordination over the last many years. Have been championing this idea, and being in a strategic position, you have been able to orchestrate different aspects across the country in different states, whether it is systematic review or whether it's a community of practice or whether it is a policy advocacy. Happy to listen. I mean, exactly the theoretical underpinnings and what you have seen in the last few years of the efforts in convincing people on approaching this aspect.
I want to tell a small story of a young IAS officer called Vikas Marmat. Vikas is posted as the chief of the Kuppam Area Development Authority. This is in Andhra Pradesh. And why Kuppam is significant is because it is the assembly constituency of the Honorable Chief Minister of Andhra Pradesh. Vikas had a headache, and the headache lasted for all of 5 months. And being a very powerful young IAS officer, he's posted in the assembly constituency of the chief minister, he got the best medical care that could be possible. So he was referred over 5 times, and every possible test under the planet was conducted. And finally, his headache could not be resolved. So they referred him to the topmost place in the country for neuro, which, as we all know, is NIMHANS, Bangalore. And their conclusion was very interesting. Their conclusion is that Vikas had what is called a refractory error. You know what refractory error is? He needed to change his glasses. So when we talk in terms of care coordination, if you cut to the chase and to the core, it is actually what Professor Sarangdeo said, it's actually a set of appointments. Because coordination is enabling both care seekers and people who help those people who seek care. You could be a doctor helping, you could be a nurse helping, you could be an ASHA worker helping, or you could be a carpenter helping. It doesn't matter. Why am I using the word carpenter? I took the health secretary of Orissa to the largest hospital in Bhubaneswar. It's called the Capital Hospital in Bhubaneswar. We went at 8:30 in the morning. And then it was an overflowing hospital, but very well ordered. So the orderly queues, very well managed for the overflow. So she went to a queue which had about 100 people on it and asked the person in front, "Aap kitna baje se yahan khade ho? Since what time are you standing here?" He said, "I've come here at 1:30 in the morning." He said, "Oh, why? What happened?" He said, "My mother has been having a sort of, feeling fuzzy in the head, and it's been going on for a long time. This is my second attempt." So then I asked, "What made you come to," and by the way, that was a neuro queue. I don't know why I'm picking neuro today, but anyway, it was the neuro queue. So I asked him, "What made you come to the neuro queue?" He said, "My neighbor suggested." So I asked, "What does your neighbor do?" He said, "He's a carpenter." So between carpenters, ambulance drivers, and security guards, ours is a health system that is orchestrated to ensure that there is 500% inflation in our OPD queues. Vikas Marmat went to 5 places instead of 1 before he met his nemesis. 500% inflation. The problem is when we talk of care coordination, the need for appointments to the experts in the health field, particularly, sir, doctors, their response is almost predictable. They say, this requires electronic health records. I have 200 people standing outside my queue. My capacity to deal with is actually 40, maybe 80. You want me to sit there and type? So I went again to Kyonjar in Orissa, where the medical college in Kyonjar, a 40-year-old woman came with what is called kujli. Basically, she had itching of the skin. So I saw her prescription for kujli. It was actually a mohar, you know what a seal. It has about 10 medicines there, of which this doctor is a skin and BD, ticked about 5. 2 antivirals, 1 antihistamine, and an antibiotic. And then she said, I also have blood pressure, referred to medical, where they gave 2 medicines for blood pressure. I mean, this is mayhem. This is mayhem. So the point I want to make is that if you can systematically triage, capture case history from the comfort of your home in a recorded fashion, people make mistakes. So, for example, in the King George Medical College in Lucknow, they actually tried the systems. Outside the OPD, they had an attendant who was sitting with a digital system, was asking the questions. So, and these questions are digitally determined. It's got an adaptive question engine, and AI today has made it extremely capable. So today, when you triage, it's not the brilliance of the doctor or the nurse, it is a combined knowledge of the entire profession that's inside that system. So you get world-class triage at every instance, because somebody says you have a headache, the next question is determined by the excellence of the entire profession. The next question is kya dono side mein hai kya? Next question is झुकने से बढ़ता है क्या? And then this entire thing, this is how a clinician, that's how you would operate, doctor. When you see me, you'll
Yeah.
first see how I'm walking, you know how I'm feeling, and then you'll ask me those questions. So, but it was very informative, because the question that was asked, I still remember, is that do you use tobacco, which is kaini. In North India, it's called kaini. It's placed between the lower lip and the tongue. And he said, so tobacco was the question. He said, मैं kaini का सेवन करता हूँ. Do you know what the entry onto the system was? It doesn't use tobacco. Not because of any mischief. So I belong to the Bihar cadre of the IAS before I retired 8 years ago. तो हमको बिहार में हम लोग एक कहावत है कि 7 खून माफ. Up to 7 murders can be excused. 8th, I do not know. So this is, and for things like this, we have a word for it. It's called lipikiyabul, clerical error. Now, when the transaction is recorded over a telephone, recorded, remember, then it is possible for you to do quality assurance by taking a sampling of them and then find out who are the people who are making the mistakes. So I'm saying that at every stage, you need observability, you need accountability, you need coordination, you need guidance. Now, what has happened is that in the last 8 months, 2 technological advancements have actually made this possible. One is, both are AI related. One is to have an extremely high quality adaptive question engine to be able to capture case history. Second is passive voice listening. Dr. Rajan Kobargade talked to you about, this problem of how do you call it, speech to text. Speech to text is one thing. Today, the capability is speech to structured data, FHIR, SNOMED CT compliant, which basically means, and I've actually tested the system, is that if you are standing in a noisy OPD and the doctor and the patient are having a conversation, do you know your blood pressure? What do you think it is? So, and actually, I got the health secretary of Shillong, Meghalaya, to actually test this. It was the World Health Summit here in Pragati Maidan, or they call it something else these days. Bharat Mandapam. And we created 10 people creating a noise. And he was asked in English and he was replying in Telugu. And when he said 70 by 120 by 70, I said 190 by 80, just to confuse the system. The system didn't pick up what I said. What I'm saying is that this is now evolving at a very rapid pace. So can we imagine, I'm using the word imagination because that's, I think, what we lack the most. Can we actually imagine a scenario where at every touch point, it could be dialysis, it could be physiotherapy, it could be an OPD clinical setting, it could be a teleconsult, we actually have listening, passive voice listening that does the recording. When it does the recording, what it does is that it calculates the time and every action is recorded into a system. And when you have this kind of observability and appointments coming together for everything, that's when I think the magic and the promise of a great health system is going to happen. And if there is one country in the planet that's going to be able to do this at a fraction of the cost, it is our own dear India. And the reason is we have the Ayushman Bharat Digital Health Mission, because the registries, interoperability standards that we have in India, I don't think any country in the world has. But Ayushman Bharat Digital Mission is still a promise. We have to ground that promise in the stark realities of our states, inspire policy leaders like Dr. Gobargade or Chief of the Director General of Health Services to be able to realize what the real promise of this is. And for that, what we need is district level, full scale implementation that harvests the complete possibility of care seekers exercising informed choice. Now, I'm talking of care seekers, but they alone will not do, because not even half the people who need care seek care. The other vast majority who need care but don't seek care, who are they? Pregnant mothers who don't come for ANC, babies who are not brought for immunization, 35-year-olds who don't come for NCD screening, people who've been screened and know they have a problem don't come for follow-up. These are just four of the ideas that I have. Dr. Abba will have a much more sophisticated version of this. But those people who don't reach out, if you have a good family health register that tracks this from birth to death with marriage in between, all digitized, then you can have outbound calls that go out and encourage people, not with आप जाकर टेस्ट करवाइए, आपको कहां, कब, किसके साथ आप अपना टेस्ट कराना चाहते हैं. That's informed choice. And when that fails, your ASHA is triggered. When the ASHA fails, the CHO is triggered. And this whole concept of community medicine, where a CHO and the entire sort of structure below her takes accountability for the health of that entire geography and the people there, that's when this will change. And I'll just, one more advocacy I want to make and I will stop, is that in government, in large systems, not just in government, what gets measured gets done. And that's why a panchayat level biannual calculation of a population health and wellness score is extremely important, because that's the North Star. That panchayat should be competing against each other, that taluk should be competing with each other, MLA constituency should be competing with each other. And chief ministers of a state can say, when I took charge, the health and wellness score of my state was 45. I promised to do 78. I've given you 85. Thank you.
Yeah. Thanks, Santosh. I think given a different dimension to the care coordination in terms of what are the possibilities of disruptive technologies in overcoming the challenges which you have given up that we cannot do. I think that's what Santosh is showing, that optimism that the technology can bridge some of the challenges. I mean, so far we have been suffering about doctors not being there, doctors, the variation between the best doctor and the worst doctor. So it's trying to say that the technology is going to democratize the cognitive intelligence of the best doctor.
Can I say something, Liz? Yes. And this is not about a perfect system working well. So if an orthopedic surgeon is confronted with a crushed bone injury, which needs to be operated upon, he needs the assistance of an X-ray technician. So what's the point in sending a patient with a crush bone injury to an orthopedician who has an X-ray technician at 7 in the evening, when when the system should know, and they don't, that at 6 o'clock the X-ray technician goes home? That level of observability is what guidance will become possible. So I was addressing at an ISB event, I was actually addressing the health officers of Andhra, and this is what an orthopedic surgeon told me: the number of amputations that we are having to do, because I'm not able to get a crush bone injury patient to a place where blood bank, anesthetist, orthopedic surgeon, etc. actually coexist and have the capacity to do that operation at that particular hour. Sorry.
No, thanks, Santosh. I think I must tell that what Rajan has said and what you have said, we are trying to actually demonstrate then in our own private healthcare, integrated healthcare system. Developing our own digital solutions, developing our own process engineering, and developing, validating how it is impacting the outcomes, both at a process level as well as at outcome level, at a patient experience level. I think by next annual conclave, we may have something to actually present. What is the impact of incorporating both the power of digital technology and the power of people process? I think the combination of these two is going to transform the health system. I think thanks again for both of you and for excellent practical wisdom. I come to Abba. I think she translates some of the interventions into a scalable, well-researched interventions. I think at a small hospital, or it is scalable at a large system level. What you're doing at a Schroff system from a quality improvement perspective, and how it can be looked at. I mean, the care coordination can be looked at from a process improvement, I think continuous process improvement to achieve the desired outcomes. Please share your experience from what you're doing now.
Thank you. Thank you, Dr. Reddy. Yes, so building on what I've been hearing since morning and sharing an example of what we've been trying to do at Dr. Shroff Charity Hospital. This is in two centers. One of them is in Alwar in Rajasthan, and the other one is in Saharanpur in UP. And the problem that we started off was, so we actually looked at the patient feedback data. So they have a very good mechanism to get qualitative data from patients. And when we looked at the data, more than 40% of the patients were complaining about waiting time. Now, this is, tier 2 city, it's not a metropolitan, but even then, time is a value that everybody appreciates, and waiting time was the foremost problem that was there. The second issue, about 15% had some issues about the medical care that was given directly related to the clinical treatment. But a very good number, 13%, had issues regarding communication and not having adequate information that was given to them. So these were the main problems that they wanted to sort of solve. And that's what we started trying to first appreciate and understand the system and from where were these problems stemming, and to really understand what is the patient flow. And we use different tools, as you said, in continuous quality improvement to understand the system from different lenses. One, we try to do an empathy map and really have with the providers interview patients, but also directly observe and follow patients to really understand what do they do. And using the empathy map and just sharing some of the reflections that I heard, we said, okay, what do patients say? And this I'm just reading out from it. They say, "Kitna samay lagega? How long will it take? I need to stand outside the OPD gate because somebody else might take my turn, so I should not step back." And thinking about, I do not know how my disease will take, how much time, how many more times I need to keep coming back again and again. And they are in this overcrowded space. Then we looked at the data to understand really what's causing the overcrowding, and we looked at data for initially for 3 months, and then we went back up to 2 years to look at data. And we could see what was the patterns of how patients were arriving. So we could identify the months when it was more busy. It's an eye care center, so we do know in winters they get a lot more patients. So that was something we already knew, but the data sort of validated that. We also looked at weeks of days of the week when there is more overcrowding. Sort of Wednesday sort of stood out really as being one of the most busy days. And then we were also able to pinpoint down to the hour, and that was actually where most of the problem was lying. What is the so they have working times from 8:30 to 5, but largely the patients were being seen between 10 to 1. And you could find that there were very few patients getting registered in the afternoon, but a large number of patients were coming in the morning. So why were all the patients all presenting 10 to 1 in a very overcrowded OPD, very worried not to lose their turn and standing over there to make sure they don't lose their place and struggling to be seen? There's another problem that came out and surfaced, and we have been talking about PMJY, and that came out in Saharanpur because it's an empaneled hospital. Rajasthan doesn't cover, I think, for most IK procedures, PMJY is not covering in private hospitals. So what it is that the patient will go to the registration desk, will get his initial registration done, will go to the optometrist, will get the initial triage and everything done, will wait for a long time in the queue, which I described, to show to the eye doctor, and the doctor will say, you need certain investigations done. Now, in eye care, many of the investigations for glaucoma do get covered under PMJY in outpatient care. Now he'll say, okay, go, and this is, we were talking about even within the hospital referral, it's okay, go to the PMJY desk and they will process it. Then he'll find his way through, go to the PMJY desk, they will have some large number of documentation requirement, and he'll say, you have to wait till your claim approval comes. And then he'll keep waiting, and the doctor will say it. Sometimes the patient will meet me at 5 and say, sir, abhi tak approval nahi aaya, what do I do? And he'll wait and maybe it will not come, and then he'll leave. And then he leaves and he comes back after a few days, and then he goes through that entire process again. And so there was a lot of dissatisfaction, particularly for patients who were wanting to get their treatment done through PMJY, the diagnostic therapy that I'm mentioning. Okay, and then of course we applied other tools. We also did the process map. We brought down step by step what are the steps in the patient flow, what the roles and responsibilities are. Should I describe all that we did in the model, or okay, maybe a few key things that we were able to test. So, in a theory of change, there were a number of ideas that we collectively gathered from right from the frontline team up to the managers who were working, the clinicians, the optometrists, and even up to the CEO of the hospital, the network. And really, this was pooled based on their collective understanding, as well as looking at literature and how other systems have solved for something like this. And based on that learning, we started using quality improvement methods to test them in a systematic manner. So using PDSA cycles, because as I said, when we went in, we were not sure what would work. We were learning. It was, as Sir described, a learning system, and we were iterative testing and testing them very small because we wanted to learn very quickly. So what can we learn in one day by making small changes? And then as our confidence increased, we ramped up the scale of testing. But few of the change ideas which have been very effective, and I can tell you the metric also that we used. One, we started something, and we were talking about appointment system. So they were having appointment system. It's not that they didn't have. There were issues in terms of inconsistency, that not everybody gets an appointment. The second issue is the appointment is given randomly. Now, if I give everybody an appointment to come at 10 in the morning, again, the problem of overcrowding would not get solved. So, and also, we also need to take into account the available capacity within the system to be able to meet the appointment. We may give appointment for 100 people, but do they really have the capacity in terms of the number of OPDs that are running over there to be able to honor those appointments that come in? So few of the things that we did is, one, we did a assessment of both the demand and the supply. So the supply is, we have information on a number of providers, number of clinics that run in parallel in that same hospital, and per hour, one doctor's clinic can see how many patients, and we can then see over 8 hours how many patients maximum are they able to see. That's the first thing. Second, we were able to go back. They have EMR records, so we were able to go back to the last 2 years' data. And as I mentioned, be able to pinpoint one per hour how many patients can they see, but also understand how many walk-in patients are coming. Because you mentioned about this cross-referral or this, suddenly you get more patients than expected than your appointments, but do you really have a buffer to manage the walk-ins? So the first thing is to create a system where they can use their own data to plan better. Second, they were able to, using the data, they knew that patients hardly come after 1 o'clock. So appointments for which they had greatest control, post-op patients who are coming on for follow-up at 1 week, who are coming for follow-up at 30 days, we were able to plan those appointments and make sure those appointments are given in the afternoon. So that sort of unclogged all that busyness in the morning and having the patients being spread out to come in the afternoon. PMJY was very interesting, and it was just a breakdown, as you were saying, in communication. The front desk doesn't know it's a PMJY patient. By the time the doctor recognizes it and sends to PMJY, most of the day is gone, and then it takes about 2 or 3 days. 2 or 3 hours for the processing to be done by the insurance agency itself. So by the time it's 5 o'clock and it's time for the hospital to be shut. So a very simple change was really making sure that there is a multidisciplinary team over there, where as soon as it's identified that the patient requires PMJY approval, they created a stamp so that the front desk knows there's a clear list of documents, and there's a conversation with the patient that we know this is the amount of time it would take. Are you happy to wait today, or do you want to come back after 2 days? Because we can start your pre-auth and it's going to be valid for 72 hours. You can come to back to the OPD tomorrow or day after and do it. So a lot of it was around just ensuring there's clear roles and responsibility. There is iterative testing of processes and communication between the different roles in the system. And these are very simple things. Didn't lead to more people being added or more just leveraging existing technology, existing people, and creating more efficiency. We did track the data. I can share that, but I've been speaking for long, so I'll just pause so you can ask more questions.
Yeah, thanks, Abha. I mean, the classical quality improvement process that you have been undertaking. I mean, unfortunately, the capacity of most of the providers, both in the public sector and the private sector, especially at the health management level, they do lack this basic management competency of quality management.
Yes, yes.
So at a policy level, at a system level, there is no attention on that aspect in terms of the management competency of basic quality of care.
Yes.
So from a policy perspective, maybe I think that should be the message that should come up is how do we actually train the health managers? Whoever is the responsible, whether it's a doctor is a manager, a nurse is a manager, or a qualified manager is a manager, do they have the competencies? Because if you have those competencies within the provider system, we don't have to struggle to learn and teach others actually, because then they can continuously improve these things. That is what I was getting the message, that now you are supporting them, but who will support thousands of hospitals and thousands of the providers? So what is the scalability of that? So that's what I think the message that was coming out. But I mean, since we are already we have eaten into the tea time, and
I could respond to that.
eating into the lunch time.
Very briefly, if I may respond to that.
Please,
I think you're absolutely right, Dr. Reddy. And a substantial amount of our effort was in building institutional capability on quality improvement. And it's not just the managers, it is quality is everyone's responsibility. So basic understanding of basic QI, the frontline staff, whether it's the community optometrists, the clinicians, the navigators, the managers, everybody was involved. But then your bigger question is, how do we scale this up? And this would require this to be, so when we were trained as doctors, I mean, I'm a pediatrician, my job was to, provide clinical care and make the child better. But now we need to move away from just providing care to how do I make my care better? And that needs to be a core responsibility of everybody within the healthcare system. And that training needs to be embedded within our medical training, our paramedical training, and we see a lot of countries who have started doing that, including training in quality and safety as a part of the core competency requirement of professional education.
Yeah, thanks, Abha. I think since Shalini already presented what I wanted to ask the question, so and also short of time, can we take one or two questions from the audience, because we did injustice to the audience so far. Quick questions, unless you're hungry and you have no patience to actually ask questions. Yeah, I think they will ask questions during the lunchtime. But some of these questions are also being taken up by the sessions on digital health, the sessions on change management, the behavior changes. So all these issues, some of these issues, in fact, we will be parking as ongoing learning sessions. These things can be taken up as a P2P learning sessions in the subsequent 12 months. So what we asked our moderators and the coordinators is to park some of the points which could not be discussed in this session because of the time constraints. I mean, so much interesting, and we won't get such wisdom sitting there again. It's but thanks each one of you, and again apologies to all of you for keeping you waiting. So we end the session here. Thanks everyone, but there were great lessons, practical lessons, as well as what are the most optimistic possibilities in terms of the digital disruption that are happening. So yeah, there is a lot more to actually learn and keep on discussing in the next 12 months as well. We may come up with much more learnings by the time of next annual conclave. Thanks again. Please break for the lunch. When are we re-meeting?
Yeah.
Please.